My name is Jorge Cortes, Cortes. I am the director of the Georgia Cancer Center at Augusta University in Augusta, Georgia. And so we're talking about the study that's called Ask for First. This is a study for patients with chronic myeloid leukemia who have been newly diagnosed, not previously treated. And they were, and it's only for adults. And patients were randomized to receive either Asciminib, which was considered the investigational option, or any of the tyrosine kinase inhibitors that is currently approved for this indication. So that could be imatinib or any of the second generation TKIs, dasatinib, nilotinib, or bosutinib. The design required that before randomization, the physician and the patient would need to decide if they were to be allocated to the control arm, which one would they choose? Would they go to imatinib or they would go to a second generation TKI just to keep that balanced? And the analysis was actually stratified by that choice. And also stratified by the risk classification according to the ELTS. So then, again, patients then received either Asciminib or one of the other drugs, all of them at their standard doses. And the primary endpoint of the study was the rate of major molecular response at 48 weeks, essentially a year. There were two primary endpoints. One is the comparison of Asciminib versus imatinib, and the other one, Asciminib versus all of the options. And so the results show that the rate of response was significantly higher with Asciminib, both against imatinib and against all the treatment options. Both of them were statistically significant, showing a significant benefit in that comparison. There was also a trend for an improvement in the deeper molecular responses, those being the MR4 and MR4.5. Those were secondary endpoints. So this is probably a little bit early to assess that, but still we started to see some improvement in that. There was also a benefit in the early molecular responses, that is the 10% or less at the 3-month mark. So all of them, all of the endpoints favored the Asciminib. Also, the safety profile was better with Asciminib. There were far fewer patients with discontinued treatment because of toxicity, about half with Asciminib than with any of the other tyrosine kinase inhibitors. And all of the adverse events that we know with tyrosine kinase inhibitors were equal or mostly better with Asciminib, meaning less frequently seen with Asciminib, both in terms of the hematologic, low platelets, low neutrophils, anemia, etc., and the other non-hematologic gastrointestinal, liver function tests, abnormalities, lipase elevation, and so on. So overall, very favorable results suggesting an improved risk-benefit ratio with Asciminib compared to the established tyrosine kinase inhibitors, and suggesting that this could be a new advance in the standard treatments for patients with chronic phase chronic myeloid leukemia as initial therapy. These may help us advance the treatment of CML. We know that we've reached already near normal life expectancy in patients with CML if they have access to the drugs and proper monitoring and proper management. But we are aiming for additional benefits. And some of these benefits are, one is very few patients can successfully discontinue therapy eventually. Only about a quarter to a third of the patients can successfully stop therapy at some point. We believe that with a drug that can get us to more of these deeper molecular responses, we can get more patients to eventually stop therapy. And these early results are suggestive that we may be in a good direction to get to that point. Of course, we need longer follow-up. The other one is better quality of life. For those patients who cannot stop therapy, having more chronic toxicities, more adverse events, and so on, limits their quality of life. And with a very favorable safety profile of asciminib, we think that if the patient cannot stop therapy, at least they probably can have a better quality of life. Again, we need longer follow-up. We are assessing quality of life, and those results have to be analyzed still. But that is the potential benefits and the potential implications for the patients and in this context. Well, certainly the main thing will be to see that we know that in prior studies, these early time points, early responses are predictive of deeper responses and more durable responses. We want to see that that's the case. And also perhaps that the patients who stop therapy, who meet the criteria, they have fewer probability of relapse. So more and more, that's becoming our goal, and it's our goal because that's what patients are asking for. So that is why we want to see. Again, that takes time, but it is encouraging. And this is very important because this is the first drug that works in this mechanism, binding this myristoyl pocket, which is very specific for ABL. So that shows that we need to continue developing new strategies for patients with CML. Although we have many good drugs, there's still always the opportunity to improve. And there are a few other drugs coming behind the asciminib that may offer additional benefits for patients who have resistance or who are not able to stop therapy. I think that that's exciting to see that there is a renewed interest in developing new drugs, in finding ways to get the patients completely off therapy eventually, and dreaming more of a cure for their patients.